Good morning. Welcome to our Department of Pediatrics Grand Rounds. My name is Suresh. I'm with the Divisions of Emergency Medicine and Health Informatics, and it's my pleasure to introduce and welcome Dr. Derek Williams, our Grand Round speaker for today. Dr. Williams is a clinical and health services researcher with a federally funded research program centered on improving care delivery and outcomes for children with pneumonia and other acute respiratory illnesses. He obtained his medical degree from the Medical College of Georgia, completed his residency at the University of Virginia, and his MPH at Vanderbilt. Currently, he leads the hospital medicine division at Vanderbilt Children's Hospital. He has contributed substantially to numerous studies that have advanced the field, including the landmark CDC Etiology of Pneumonia in the Community EPIC study, the largest prospective investigation of pediatric pneumonia hospitalizations ever conducted in the US. He has been continuously funded since 2008 with multiple grants from NIH, CDC, AHRQ, and PCORI. He has served as an invited speaker at scientific conferences and academic institutions nationwide and received awards recognizing his scientific contributions from the Academic Pediatric Association, the Infectious Diseases Society of America, the Pediatric Infectious Diseases Society, the American Academy of Pediatrics, and the Society of Hospital Medicine. He's also a member of the Pediatric Pneumonia National Guideline Committee. Dr. Williams has authored over 130 peer-reviewed publications. He's an active research mentor with 9 current trainees and junior faculty mentees, including 2 K awardees. He also serves on the Executive Council for the Pediatric Research in Inpatient Settings, PRIS network, which is an independent hospital-based research network that has garnered over $32 million in federal grants. In our department, Dr. Judy Martin from General Academic Peds and Dr. Nancy Ricks from Emergency Medicine and myself have had the pleasure of collaborating with Dr. Williams recently on a funded grant, and were able to implement the pneumonia decision support tool based on a collaboration into our EMR here. Please join me in welcoming Dr. Williams.
Thank you, Suresh, for that introduction. It's a pleasure to be here in Pittsburgh. I visited Pittsburgh a few years ago in the before times. I sort of fell in love with the city, and obviously have gotten to know several folks, Judy, Suresh, Nancy, et cetera. And it's wonderful to be back, so thank you very much for the invitation. I spend a lot of my time thinking about pneumonia and a couple of different areas that we focus on, but one is really around healthcare delivery and thinking about antimicrobial stewardship. So that's what I want to talk to you all about today. Just quick disclosures: my funding sources, NIH, CDC, and AHRQ. So outline for today, I want to first just set the stage and the importance of antibiotic use in children, specifically just highlighting antibiotic prevalence and overuse as an important issue, and how we're thinking about that issue with childhood pneumonia, thinking about antibiotic choice, as well as efforts to shorten antibiotic duration, and I'll close with just a couple of slides on a couple of teasers of things to come. All right, so some of you may be aware of the Choosing Wisely campaign, first initiated by the American Board of Internal Medicine, has since spread to a number of different organizations, including the AAP. And really, these Choosing Wisely is around the idea of implementing evidence-based medicine and also de-implementing areas where there's not a lot of great evidence. And this is the 10 things physicians and patients should question that the AAP, they're choosing wisely. Their iteration at the very top is use of antibiotics, and really emphasizing not using antibiotics for viral respiratory illnesses, which seems like kind of a no-brainer for us. But they go on to describe what they're talking about: sinusitis, pharyngitis, bronchitis, and bronchiolitis. I would like to posit that we should also be thinking about pneumonia as one of those areas where viruses are very common. And why is this an issue? Well, inappropriate antibiotic use is problematic. As we know, all therapies can have side effects, and if you don't need those therapies, they can be challenging with, they're inconvenient and can be associated with higher costs, obviously adverse events, and as we all know, important contributor to antimicrobial resistance. And so just to talk about the scope of the problem, this is a study from a national database called NAMCS and HAMCS, a population-based database that looked at the prevalence of inappropriate antibiotic prescriptions among ambulatory care visits. And this is just data for, I'm just highlighting the data for children less than 19 years of age. Overall, annual outpatient antibiotic use totaled about 646 antibiotic prescriptions per 1,000 U.S. children. So about 64%. Acute respiratory illnesses actually accounted for a full 2/3 of those prescriptions. So a lot of antibiotics being used in children, a lot of antibiotics being used for acute respiratory illnesses. And they tried to quantify what proportion of those antibiotics were considered inappropriate for the wrong indication, et cetera. And a full third of those antibiotic prescriptions were considered inappropriate according to their definitions. And I've seen estimates as high as 50%. In terms of inappropriate antibiotic prescribing, but just a big issue, as you can see in the ambulatory care setting. And in the hospital setting, which is where I practice, it's also a big issue. So antibiotics are used very commonly in the hospital setting. This is illustrated nicely in this study from Jeff Gerber and colleagues from 2010, where they looked at antibiotic use at over 30 children's hospitals. Overall, they had about 500,000 patients, nearly 3 million patient days. Antibiotics were received in about half of all hospitalizations, and nearly 70% of patient days, so 698 antibiotic days per 1,000 patient days. So just a boatload of antibiotic use. And why pneumonia, and why we're talking about pneumonia today, and why I think that's important. Pneumonia accounted for 4% of all antibiotic utilization in this study, and it was the highest among any single condition. So if we're thinking about stewardship, in the hospital setting where I practice, pneumonia is certainly an important target where we can make some improvements. I think one of the other reasons, one of the other things I want to highlight is what we know about etiology of pneumonia, because it's complicated. It's not a single disease. It's quite heterogeneous, and this is illustrated in this study that we participated in. This was the CDC Etiology of Pneumonia in the Community Study, the 3-center population-based surveillance study of pneumonia etiology. We enrolled about 2,000 hospitalized children with pneumonia, used comprehensive diagnostics to look for viruses and bacteria, culture-based methods, PCR, serology, et cetera. And that's what you see in this graph here. The various pathogens are along the x-axis, and the percent of positive, or percent of patients with positive detections for each pathogen along the y. But the take-home message here is a lot of viruses. We found a lot of viruses in these children with pneumonia, about 70% RSV being common, rhinovirus and human metapneumovirus all being very common. In contrast, bacteria were much less common. Mycoplasma was the most common bacteria identified in about 10% of patients. Streptococcus pneumoniae identified in about 5% of patients. And just to pause there for 1 second, importantly, strep pneumo historically has been far and away the most common cause of classic bacterial pneumonia. And in etiology studies conducted prior to pneumococcal conjugate vaccine, much more likely to recover pneumococcus in those studies, as high as 50% of cases of pneumonia, strep pneumo has been implicated. So this is a big difference. So a lot of viruses and not a lot of bacteria. What do you guys think about antibiotic use? About 90% of children received antibiotics in this study. So the question is this appropriate or not? Certainly I don't think 90% is the right target, but I think we have to also remember a couple of things. One, these are children who are sick enough to be in the hospital, and two, we know that our diagnostic tests are imperfect. It's fairly easy to identify a virus from the upper respiratory tract. Whether that's causing disease in the lower respiratory tract is sometimes a question, sometimes for certain pathogens more so than others, rhinovirus being a good example there. In contrast, our ability to identify bacteria is much less. Just the diagnostics that we have for bacterial pneumonia, it's hard to sample, obviously, the lower airway and yield of culture-based methods and sensitivity of diagnostics in general for bacteria far lag. So I do think that there's some inappropriate antibiotic use here, so I think it's somewhere in between in terms of the prevalence of classic bacterial pneumonia, but no question viruses play a critically important role here. All right, so with that background, I want to talk now a little bit about antibiotic choice for childhood pneumonia. And here we do have national guidelines. So the PEDS-ID Society, Infectious Disease Society of America in 2011 released the first consensus guidelines for the management of childhood pneumonia. There were 90 plus recommendations in that guideline, something like that. And the recommendations around antibiotic use were some that were supported by some of the strongest evidence. So just to highlight some of that. So in the outpatient setting, there was a recommendation for actually withholding antibiotics for those less than 5 years of age, again citing the commonality of viruses, especially in young children. If you are using antibiotics in the outpatient setting, a strong recommendation to use amoxicillin in most instances. Again, strong recommendation, high quality evidence. It's a good antibiotic for most of the bacterial pathogens that we're thinking about that cause pneumonia in outpatient settings, specifically strep pneumo. And then there's this consider for macrolides in older children and adolescents. If you have mycoplasma confirmed, or if you have findings compatible with mycoplasma. And if anyone here can tell me what the difference between mycoplasma and viral pneumonia based on clinical findings, I would love to buy a cup of coffee and talk about it, because it's quite difficult. But this was a weaker recommendation. There's less evidence here, and we'll get into some of that. In the inpatient setting, it's very similar. We're using more parenteral antibiotics here, but the antibiotics are virtually the same, using ampicillin in most instances in uncomplicated pneumonia. So again, strong recommendation, high quality evidence. Again, we have this recommendation of considering use of macrolides. That hasn't changed, and now we see considering use of anti-staphylococcal therapy. Staph pneumonia is uncommon overall, but boy, when you see it, it's quite severe, and so it is a strong recommendation to consider treatment for anti-staphylococcal therapy when there's concern for Staph aureus. So that's the background in terms of what the guidelines say. Now I want to kind of talk a little bit about how we are doing, or how we were doing. This is a study in the outpatient setting. I'll kind of do outpatient ED and inpatient. In this study, this was actually done here in Pennsylvania, I think across the state in Philly, looking at antibiotic utilization for pneumonia in a primary care practice network of 31 practices. They had about 10,000 patients. About 40% of them received amoxicillin, that guideline recommended treatment. 43% recommended received macrolides, and 17% received broad spectrum. So we already see kind of a disconnect between what's recommended and common practice. But what I thought was most striking is the variability that you see by site. That's what you see in the two figures below. The clinic sites are along the x-axis. The probability of receiving either a macrolide on the left or broad spectrum therapy on the right by clinic site. And you can see, just based on what clinic you go to, can predict the probability that you're going to receive non-guideline concordant therapy, for macrolides ranging from 20% all the way up to 80% or more. So a ton of variability. When we see that kind of variation, Do we think that that's because of differences in the patients? Sometimes, but obviously this is a primary care practice network in a single metropolitan area. We know that that variation is very likely unwarranted. It's not tied to differences in the patient population and illness severity. So that's variation we want to try to eliminate. Similar story if you look at the ED setting. This is data from HAMSES, again, population-based database, and gives you US-based estimates. And here again, looking at antibiotic use for pneumonia. Here they split it up by different age groups, preschool-age children and school-age and adolescents. But the story is similar. Again, penicillin's less common, even more so in this study, 27% in the youngest kids and 11% in the older kids. Cephalosporin's more common, 40% and 27%, and then macrolides even more common, 37% and 64%. So we're seeing more macrolide use, more cephalosporin use, and less penicillin use overall. And then if we move to the inpatient setting where I work, it's even worse, I think, if you're thinking about appropriateness of prescribing in accordance with the guidelines. So this is a study from 29 children's hospitals, administrative database study from FIS, 21,000 children. You have the stacked bar is by hospital, so you have hospitals along the x-axis, and each bar represents a different antibiotic class or combination of antibiotics. And anything in blue here in different shades of blue are cephalosporins, alone or in combination with something else. So vast majority of children receiving these cephalosporins. The green is guideline recommended immunopenicillins. And as you can see, very, very few hospitals have more than even 5% use of narrow-spectrum therapy. Now, this was before the guideline was published, so understanding that, but clearly it shows you that we have a lot of room to improve here. I didn't pull out macrolides here, but because it's kind of hard, they're embedded with some of the others, but it's about 30% macrolide use in this study. So how have things changed? We've started to do a few studies to look at how things have changed since the national guideline. This is the one that I participated in, same database that I just talked about, FIS database. So these are almost all the same hospitals that I just presented. We had 28 hospitals, and we were looking at antibiotic use 42 months after the guideline was released, so about 2.5 years. Certainly enough time that you would think for some of that to be disseminated. And then we looked at uptake of narrow-spectrum therapy, essentially as a function as a change from what would have been expected had the guideline not been published. And so anything above that horizontal zero line is considered more use of narrow-spectrum therapy. So overall, we saw an increase about 27 percentage points. So we did see some moving the needle, but again, it's that variation that we see with some hospitals having a lot of uptake, more than 50%, and then some hospitals having very, very little. And remember, almost all of the hospitals I showed you had a lot of room to improve. So not seeing the reliable increases that we would like to see. Now, back to the outpatient setting, similar question, how have things changed since the guideline? We have a little bit more data here, all the way out to 2016, guideline published in 2011. And this is very similar setup. We have narrow-spectrum therapy, the ampicillin and mox. We have broad spectrum. The narrow spectrum is the green. I think those are circles. Broad spectrum is the purple squares, and then macrolides the triangles. But and we have it split out by the different age groups. But overall, I think we do see some moderate increases in narrow spectrum therapy. I think you can appreciate that most in the youngest children. But we don't really see a lot of change in use of other therapies, and very modest decreases in use of macrolides. If you look at the 5 to 12, it's about close to 60%, and more than 80% in the 13 to 18-year-old age group. So a lot of macrolide use in those groups. And So why so much macrolide use? This is a really interesting question. We use a lot of macrolides. You go back to the etiology data from EPIC. Again, about 10% of children had mycoplasma detected. It varies by age, so we know that school-age children and adolescents especially are much more likely to be infected with mycoplasma as compared to younger children. That's what you see in these the pie graphs at the top here with these 5 to 9-year-olds and 10 to 17-year-olds. So it is true that we see more mycoplasma in the older children and adolescents. So you may see more mycoplasma or more macrolide use in that population. So really the question is why, though? Certainly macrolides are convenient. Once a day for 5 days sounds pretty good. They've been aggressively marketed for years and years. At one point, azithromycin was the single most common outpatient antibiotic across all ages, adults and children. The issue, though, is excessive use of macrolides is really problematic. Excessive use of any antibiotic is problematic, but macrolides especially. They're associated with the development of antimicrobial resistance and multi-drug resistance, and they're not great for other bacterial pathogens that are common like strep pneumo. And probably the most important is the question, are macrolides effective? And there's just not a lot of data out there to really answer this question. So it's, I think it's somewhat unanswered. I'm going to show you a couple of slides, though. There have been a few randomized controlled trials that have tried to look at the efficacy of macrolides. This one's was from Chile from the late 90s. And it's just a small study, 47 children with pneumonia comparing azithro versus amox. They looked at outcomes at 3, 7, and 14 days. The only difference they found was at 7 days, but not 14. We had improved chest X-ray in the azithromycin group, but no other differences in any of the other important outcomes that they were looking at 3 or 14 days. So not a ringing endorsement there. And there have been 3 additional randomized trials that have failed to demonstrate benefit of macrolides, either alone or in combination with beta-lactams. The question is certainly still out there. Again, not a lot of randomized trials. In the absence of randomized trials, we can go to observational data and try to learn some things. So we were able to leverage the EPIC study to ask a question like this. So we had about 1,400 children in the EPIC cohort who received either beta-lactam monotherapy or combination therapy with a macrolide. And so this is an observational study, so we use multivariate adjustment, propensity score matching to try to adjust for confounding, et cetera. And our outcome was time to discharge from the hospital. And in this study, we saw no differences in time to discharge for children who received combination therapy as compared to beta-lactam monotherapy. And we also looked at important subgroups where we thought macrolides might be most beneficial. So kids over 5 years of age where mycoplasma is more common, those who actually had atypical bacteria detected, those who were admitted to the ICU, and those who had acute wheezing. Now, these are subgroups, so sample sizes are small, our ability to detect small differences is limited, but across all of these subgroups, there were no differences in time to discharge, so for the overall or for any of these subgroups. Now, here's another study that asks the exact same question. This is an administrative database study from FIS again. Same question, beta-lactam monotherapy versus macrolide combination therapy. Outcome again, looking at length of stay. Many more patients, had about 20,000 patients in this study compared to the 1,400 that were in the EPIC study. Obviously, with administrative data, we have less granular information. It's harder to adjust for certain confounding variables, et cetera. Nonetheless, in this study, they actually did demonstrate that macrolides were beneficial, being associated combination therapy being associated with a reduced length of stay overall. And they broke it out by age groups, and it was the 6 to 11 years and 12 to 18 years, so the older children and adolescents who benefited from the macrolide therapy with shorter length of stay. So as you can see, there's kind of data on both sides and not a robust amount of evidence for us to draw significant conclusions. I didn't come up with that conclusion. This is the conclusion of a couple of systematic reviews and meta-analyses who have already looked at this question, and they both concluded the same thing, really insufficient evidence for or against use of macrolides to treat atypical pneumonia, such as mycoplasma. So the jury is still out here, and a lot of work, I think, needs to be done. So to summarize here, narrow spectrum aminopenicillins are underutilized. These are the guideline recommended treatment in most instances. This is across all settings, but in the outpatient, especially inpatient setting. Again, recommendations supported by strong evidence, so we should feel good about following these recommendations. I've highlighted the overuse of macrolides as being particularly problematic. This is more so in the outpatient setting, where prescribing far surpasses the prevalence of atypical pathogens. Again, the issue with efficacy, which I think is really important. My own practice, if I'm compelled to treat, I'm really going to test for mycoplasma. I think most of us have in-house mycoplasma testing now with PCR. It used to be you had to send these out, and it wasn't really that helpful because they've already completed their treatment course. But now, if I feel compelled to treat, I can test and quickly stop therapy if their test is negative. All right, so we've also shown the national guidelines can be helpful, but clearly insufficient for us to really make that wholesale change that we're looking for. So how do we improve? How do we do better? So a couple of examples. This one is a single center study that looked at the effect of a local clinical practice guideline as well as implementation of a stewardship program. And they demonstrated implementation of the stewardship program followed by implementation of the clinical practice guideline led to important decreases in use of ceftriaxone and increases in use of narrow spectrum ampicillin therapy. So local clinical practice guideline can be helpful. Stewardship programs, which are virtually ubiquitous now, it feels like in children's hospitals, can be very, very useful, and often those two things work in concert together. So stewardship, especially, I think, has also been applied in the outpatient setting. This is another study from Jeff Gerber and colleagues in Philly, a cluster randomized trial of an outpatient stewardship, again, for reducing broad-spectrum antibiotic use. This is an acute respiratory illness, not just pneumonia, but what they demonstrate is that over time, implementation of the stewardship program led to declines, sustained declines, I will say, in use of broad-spectrum antibiotics. So the stewardship can be very beneficial. One area that leads us, and this also was an idea that sort of led us to our ICECAP study, which is the study that Judy and I and Suresh and Nancy all collaborated on, was really asking the question, where, stewardship is great. It's really hard, I think, to do in the emergency department environment. It's a very fast-paced environment, as we know. It's busy. It's sometimes chaotic, and that stewardship that you want to do, or our stewardship colleagues want to do, is very, very difficult, I think, in the emergency department. So we said, well, what if we could use clinical decision support to do this, right? So enter ICECAP. This was a randomized trial that we just finished not too long ago and was just published in the Journal of Hospital Medicine. And you guys may have helped to care for some of these patients. But what I want to say about this study also is, in contrast to traditional randomized trials, highly controlled, et cetera. This is a pragmatic randomized trial, pragmatic in the sense that it's embedded within clinical care. So we're really trying to look at the real world effectiveness or real world efficacy of these interventions in the very messy clinical environment that we all live and work in. So contrast that with your well-controlled clinical trials. So at Vanderbilt and here at Pittsburgh, you have your child with pneumonia who presents for emergency care. There are about 1,800 children that we assess for eligibility. We randomized about 1,000 children to a usual care arm or this clinical decision support arm, which I'll tell you a little bit more about. Our outcome was guideline concordant antibiotic prescribing. And again, everything about this study, screening, enrollment, randomization, was all embedded within the EHR and clinical care. And so we did not consent patients. We sought and obtained a waiver of informed consent. We did not have research assistants who were enrolling subjects and whatnot. This was all embedded within clinical care. And so what does the clinical decision support tool look like, the intervention? It's pretty straightforward. We just asked, it's based on site of care. So if you're being discharged home or, or being admitted to the hospital or going to the ICU, you're probably going to get different recommendations. And then we asked just a very small number of questions that would help us to inform what the antibiotic choice should be. So we certainly took care of the garden variety uncomplicated pneumonia neurospectrum therapy, but we also tried to target, are you concerned about aspiration? Are you concerned about staph? Are you concerned about severe pneumonia, et cetera, et cetera? And that led to these tailored antibiotic recommendations, which were fed back into the EHR, into the clinicians. So that was the intervention. So how did we do? This is, again, guideline concordant antibiotic prescribing. We have overall, this was our primary outcome. About 50% of children received guideline concordant therapy. There was no difference in the CDS arm as compared to the usual care arm. So we did not see increases in guideline concordant care with CDS. However, if we look at by disposition, we see, first of all, those who are discharged home had the highest guideline concordant treatment, and we saw a significant effect of CDS, about 50% increase in guideline concordant therapy with this intervention, going from 66% to 75%. And you can see for inpatient and ICU, no differences, but you also see less and less guideline concordant prescribing in those settings, which I personally think has a lot to do with, well, there's a lot of reasons that might be. I think there's a lot of diagnostic uncertainty. There's much more complexity, illness severity in the hospital, and that leads to more concern, diagnostic uncertainty, and more likely to prescribe broad-spectrum antibiotics, et cetera. The other thing I wanted to highlight is the conduct of this study also happened to fall during a period, you guys may remember in March of 2020, a new virus came along, and this is not from the IceCap study, but this is another study that we did that just looked at respiratory hospitalizations and non-respiratory hospitalizations at the onset of the pandemic, and as we all experienced dramatic declines in respiratory disease and hospitalizations in general in the early period of the pandemic. It just so happened that when we were doing this study was throughout this pandemic period, and two things. One, we were actually excited that we were able to continue this research because a lot of research got shut down during that time. We were able to continue to do this because it was all embedded within clinical care. We would not have the non-essential research staff in the ED and things like that. But it also got us thinking, this is somewhat of a unique experiment also, and we realized in some of our qualitative work that during this time, clinicians clinicians were very hesitant to want to engage, to use these new tools. We all just kind of wanted to get our work done and kind of move on and not have to think about new things, all that cognitive load that we're all experiencing during the pandemic. And so, but at the same time, we also, talking to people, found that they really liked the tool. When they actually used it, they said, hey, this is really useful. And so that gave us the idea, well, what if we looked at kind of the per protocol analysis, meaning if you use the decision support as intended, you went through the recommendations, you got the recommendations, did you improve? And so that was what we did, and that's what you see here. So this forest plot, these are odds ratios, just like the odds ratios I showed in the table before, and we have some subgroups here, but just focusing on the overall first, we did see significant differences in guideline concordant prescribing overall in that per protocol analysis. Again, this is only about 50% of subjects, but when used as intended, the intervention does seem to work, and you can see these odds ratios really around 2 and greater, 2 to 4, so much larger effect sizes as well. That difference between effectiveness and efficacy also tells us implementation, right, is so critically important for this type of healthcare delivery research. All right. I want to transition now to another area where we're trying to think about stewardship. We've talked about antibiotic choice and limiting antibiotic spectrum is really efforts to shorten antibiotic duration. And another collaboration with Judy and you guys here in Pittsburgh. So we know that according to national guidelines, 7 to 10 days of antibiotics is most commonly prescribed. That's what I certainly was taught, and I think most all of us, and that is most common in clinical practice. And really the question though is, can we effectively treat pneumonia with shorter durations? And I know there's a lot of studies that are starting to think about this, and not just pneumonia. I know the SCOUT UTI study just came out as well. And so, if you look at, in the case of pneumonia, there have been a handful of studies, including 3 studies over the past just couple of years that have looked at this question. These are all randomized trials looking at 3 or 5 days versus 7 to 10 days of antibiotics for pneumonia. Most all of these are non-inferiority trials, but they all tell the same message. And you can see in this forest plot in the summary odds ratio here, no difference in outcomes for long course therapy versus short course therapy. So concluding that short course is non-inferior to the more standard course therapy. But we were actually interested in saying, can we do better than that? Non-inferiority designs have their own idiosyncrasies in design. We were really interested in saying, can we think about more globally about the patient experience to demonstrate that maybe 5 days is actually better because we know antibiotics have side effects and whatnot. And so that was really the genesis for ScoutCap. So this was a collaboration with Antibiotic Resistance Leadership Group and NIH, and was run through the Vaccine Therapeutics Evaluation Unit. So, and here in Pittsburgh was one of our sites, but we had 8 sites. And what we did is there were some pragmatic aspects to this study as well, in that we enrolled patients after they had been diagnosed with pneumonia by their clinician and prescribed an antibiotic. This is all outpatients. These are young children. And then we enrolled them assuming they had demonstrated some early clinical improvement. And they were randomized to 5 days of antibiotics or to 5 additional days. So they got 10 days total. So 5 versus 10. And then we looked at this assessment of adequate clinical response at our outcome assessment visits about 2 weeks after starting therapy. And the way that we looked at this kind of global assessment of of outcomes. Instead of just saying treatment failure, yes, no, sick, not sick, we looked at a ordinal outcome where we looked at both that question of treatment failure, which we call adequate clinical response, but also persistence of symptoms. So if you get better but you still have a cough, that would be persistent symptoms. And then we also looked at antibiotic side effects. The way that this works, and the first 5 categories are everyone who had no treatment failure. So these are ranked by best to worst. So the first 5 groups, no treatment failures, and you distinguish based on whether they had persistent symptoms or antibiotic side effects. And then the last 3 categories are those who had inadequate clinical response or treatment failure. That could be an ED visit, that could be hospitalization, or that could be death. And the way that this works is you consider the overall clinical outcome, right, the harms and benefits, as we've said. You rank subjects according to this ordinal table, and then you compare between groups. And antibiotic duration, we incorporate antibiotic duration as a way to break ties, meaning if you had 2 patients who had the same rank in terms of their clinical outcome, the patient who received a shorter duration of antibiotics was judged superior because they achieved the same outcome with shorter durations of antibiotics. That was a priori hypothesis. And that's where we call it radar, response adjusted for duration of antibiotic risk. That was our primary outcome. It's a little complicated, so I feel like I have to explain it. And this is what we found. So these are our results for the distribution of patients. First of all, we enrolled just under 400 children. Over 90% of them had this adequate clinical response. And as you can likely see, very few differences here in the 2 groups. And you can also see cumulative risk differences as you go down the ordinal scale. No differences. We did have about 6 to 7% of children who had persistent symptoms, but very few children who actually had inadequate clinical response. We had no hospitalizations and no deaths. And this is that outcome, the primary outcome. So we have the DOOR outcome. That's that ordinal table that I talked about, ignoring antibiotic duration. Here, and the way that you think about this is we have probability of more desirable outcome for short course treatment along the x-axis, and 50%, that's like the flip of a coin. So if you're crossing that 50% threshold, that's like no difference, right? It's like chance. So if you're on one side or the other of that, then you do see a significant difference favoring one or the other. So for the DOOR outcome, without considering antibiotic duration, there was no difference. So what that tells us, similar clinical outcomes for the patients in both groups. But then when we add in the response adjusted for duration of antibiotic risk, the actual duration of antibiotics received, the short course wins out. 69% of the time probability of having a better outcome. So similar clinical outcomes with shorter durations of antibiotics. That's how we say that 5 days it was judged as superior. And we actually do have some objective evidence to also support this. So this was a sub-study conducted by Melinda Pettigrew from Yale, a collaborator, and we collected samples from the respiratory tract of children who were enrolled and looked at the antimicrobial resistome in both for total resistance genes as well as beta-lactam resistance genes. So we're just looking for antimicrobial resistance in the microbiome of the throats of these children. What we showed is that in the short course group, they had fewer antibiotic resistance genes in total as well as in beta-lactam resistance genes. So shorter antibiotic courses associated with fewer resistance genes in the respiratory microbiome. So again, some objective evidence to support those findings. All right, so pneumonia, I hope I've convinced you, is an important target for stewardship efforts. We've talked about antibiotic choice, narrow spectrum penicillins being underutilized, overuse of macrolides. We need more data here. I've talked about local implementation efforts being really important. And antibiotic duration, really moving toward shorter courses of antibiotics for pneumonia, certainly in the outpatient setting, and I think we're trying to figure out how to do this in the inpatient setting as well, certainly with those children who have just mild illness who are in the hospital for a short period of time. I think those are likely candidates for short course therapy also, although there's less evidence in that area, so that's more just my own personal belief. The million-dollar question, though, is can we avoid antibiotics altogether? And this is really, I think, a lot of folks trying to think about this question. There is a disconnect between etiology and antibiotics. It's really hampered by our ability to identify reliably bacterial pathogens, especially. The poor sensitivity of bacterial diagnostics just makes this really challenging. If you've ever been on this side with a patient who with pneumonia, breathing fast, and looking like they need to go to the ICU, it's hard to make that determination. This child likely doesn't have bacterial disease, or I'm going to cover them just in case. So there's a lot of work in this area being done, a lot of interest in looking at biomarkers. Procalcitonin is probably the one that has received the most attention and has an FDA indication for guiding antibiotic decision-making, but there are other biomarkers being explored. There's a lot of work around transcriptomics and the host response that folks are thinking about, including our group. And so this is just a quick teaser for the future. Some work that we're currently doing. This is looking at RNA expression, RNA sequencing study, and this is a heat map and we'll call it upset plot and a Venn diagram down there. But essentially, trying to look at differential expression of genes in children who have pneumonia versus those who do not, and also trying to use those host expression patterns to understand differences between etiology. So in this study, where we looked at about 200 children with pneumonia and about 45 healthy controls, 200 children from the EPIC study where we have really good etiology data. About 6,000 genes are differentially expressed, either over or under expressed in pneumonia as compared to healthy. That's a lot of genes, obviously. About 3,000 of them, about half, are conserved across all etiologies, so maybe a marker for the disease itself. But a much smaller number of genes, we've identified about 30 genes that may help us discriminate among these important etiology groups like bacterial disease, atypical bacteria, viruses, and some other data on severity as well, which is another area that I focus on. So more to come here as we kind of wade through these data. I'm learning a lot, I will say. This is a new foray for me, so I'm learning a lot about this work and learning from others. And then I'll just close with maybe a cautionary tale that gets back to that issue of implementation. Again, a lot of interest in procalcitonin, and it has been shown to reduce antibiotic use in randomized trials in certain populations. Here's one example of that from Switzerland from several years ago. Randomized controlled trial of 337 children. On the left are children with pneumonia, and in that group, the procalcitonin group was associated with a reduced odds of receiving any antibiotic, the odds ratio of 0.66, and reduced antibiotic duration by about 3 days. So that's exciting. But if you look on the other side, this is the non-pneumonia LRTIs, and I'm trying to rack my brain to think about what are the non-pneumonia LRTIs. We're going to be using a lot of antibiotics. And so I think there's a lot of viruses over here is what I'm saying. But the non-pneumonia LRTI group, those who had a procalcitonin were 4 times more likely to receive antibiotics. So the group where we think viruses are probably even more common, the procalcitonin actually is leading to use more antibiotics, and just a short difference in, well, no difference in actually antibiotic duration, but more antibiotic initiation. So a cautionary tale there about implementation. So in addition to that antimicrobial stewardship, this idea of diagnostic stewardship and how those two things go hand in hand. So I will close just by saying there is a huge group of people and individuals that help to make all of this work possible, and I couldn't do it without all of them, and certainly the wonderful people here in Pittsburgh, Judy, Suresh, and Nancy, and others. And with that, I will say thank you, and I will take any questions.